hello to everyone, and welcome to the first webinar of the M8 Alliance series on migrant and refugee health, organized in cooperation with the Lancet Migration Commission. My name is Luciano Saso, and I'm a Vice Rector at Sapienza University of Rome and member of the Executive Committee of the M8 Alliance. First of all, I would like to introduce Professor Axel Priess, President of the World Health Summit and Dean of Charité. Unfortunately, he was not able to join us today due to another important engagement, but he was very kind to prepare a video message for us.
Dear ladies and gentlemen, it's my very great pleasure to greet you to the M8 Alliance webinar series on refugee and migrant health, organized by Luciano Saso, in my capacity as the President of the World Health Summit. Maybe I'm allowed to make a few remarks about the World Health Summit and the M8 Alliance, because not all participants may be aware of their roles. The World Health Summit was founded in 2009 together with the M8 Alliance and was always supported by the German Chancellor Angela Merkel, by the French presidents Macron, and the President of the European Commission, Ursula von der Leyen, as well as Tedros, the Director General of the World Health Organization. It brings together leading international representatives from science, politics, industry, and civil society, each year in Berlin, but also in regional meetings around the world, always held together with our M8 Alliance partners, which are outstanding medical institutions in many countries around the world. The M8 Alliance, by this, is the academical backbone of the World Health Summit. And the regional meetings show the interest in global health, which is promoted by the M8 Alliance meetings around the world. As the incoming president of the World Health Summit, I am very enthusiastic to steer these very relevant entities into the next round of their activity. World health and global health is becoming more and more important, as it's easily seen from the current pandemic. And I'm extremely grateful to the President Detlef Ganden, who has brought the World Health Summit and the M8 Alliance to the level where it is now by his knowledge, his enthusiasm, his friendship, and his extremely broad skills in the area. Global health is a central activity for the Charité, which is in turn one of the major hospitals in Germany and in Europe. And the World Health Summit is one of the outstanding flagship activities of the Charité. And as you may know, the Charité has also played a relevant role in the current pandemic, and we are very grateful that we, for instance, host Christian Drosten here, who is advising us and the German government in the responses to this pandemic. Now let me make a very brief remark with respect to the webinar series. 2020, as you all know, was extremely challenging, but it has boosted digital communication, and we all learned a lot about how to behave and how to arrange and how to technically master these kinds of digital communications. And it offers the possibility for people to come together even if they cannot travel or don't have the time to travel. And therefore it's also a chance. And I thank Luciano and his team very much for the initiative to run this webinar at this time. And they have chosen a very, very relevant topic for the pilot series. Migration and refugee health has been on the agenda of the World Health Summit for several years, also pushed strongly by Luciano and his team, with regular sessions and series of expert meetings and resulting publications. Migration and health is also very relevant for the Charité, with many research groups here working on topics like refugee health, migration and mental health, and also the recently founded Berlin University Alliance, which is the three major Berlin universities together with the Charité, have put global health very high on their agenda. I'm looking forward to the series, and I firmly believe that international and interdisciplinary collaboration is really key to achieve the Sustainable Development Goals and to find solutions to the world's most pressing global health challenges. Migration and refugee health is one of those, a very special one, and this is again highlighted in the times of pandemic, and it's our common duty to address it, and I think this webinar series will be a very good way to do that. Thank you very much for your attention, and I wish you a very fruitful and successful webinar, and I thank again Luciano for taking the initiative. Thank you very much.
Many thanks to President Pries for the very interesting message and his very kind words. Special thanks also from me to Professor Dr. Ganten, the founding president of the World Health Summit and the M8 Alliance, who obtained exceptional achievements in the last 11 years, managing to put global health as one of the top priorities for many universities and academic centers, connecting high-level figures in academia, industry, and international organizations. For the organization of this webinar, I would like to thank very much Nora Anton, who did an amazing job in cooperation also with Daniela Levy and Friederike Sonntag, and I know that the whole excellent World Health Summit team, directed by Jörg Heldman, was involved. Migrant and refugee health has been an important topic for the World Health Summit since 2016, and many sessions were organized at both the annual event in Berlin and at the regional meetings. In addition, we organized expert meetings at Sapienza University of Rome in 2017, 2018, and 2019. The expert meeting planned in Rome in 2020 was postponed due to the COVID pandemics, and we decided to launch this series of webinars. We are now planning monthly events which will cover several topics such as health issues in massive migration areas, COVID vaccination campaigns, digital health, improving the healthcare systems, mental health, accessing the healthcare systems by undocumented migrants, and others. For each event, we are going to partner with a different institution. Today's webinar on the impact of COVID-19 on migrant and refugee health has been organized in close cooperation with the Lancet Migration Commission. And I would like to thank very much Miriam Arkut for all her work. Miriam is a senior research fellow in global public health and forced migration at the Institute for Global Health of the University College London and the executive director of Lancet Migration. She is a trained medical doctor and works regularly as a public health and humanitarian consultant on migration and health. I would like to thank very much Miriam for chairing the panel we are going to have today and all the distinguished speakers for accepting our invitation. Thank you also to Professor Stephen Matlin from the Institute of Global Health Innovation of Imperial College London, who will be the rapporteur of this meeting. I would like to thank very much all the participants for being online with us, and I invite all of you to ask questions in the chat in view of the discussion which will be open up after the presentations. Without further ado, I wish to everyone a very pleasant and fruitful meeting, and I leave the floor to Miriam.
Thank you so much, Luciano, and also thank you to the M8 Alliance and the World Health Summit, and especially to our speakers for joining us today, and welcome to you all. It's a great pleasure to be here on behalf of Lancet Migration, which is a global collaboration between the Lancet and researchers, implementers, and others in the field of migration and health, that aims to address gaps and drive policy change, building on the recommendations of the UCL Lancet Commission on Migration and Health, which was published in December 2018. Since the start of the COVID-19 pandemic, there has been great concern about the impact of the pandemic on some of those most marginalized within our societies, including migrants, refugees, and asylum seekers. In May 2020, Lancet Migration published a global call to action, which highlighted the urgent need to include migrants and refugees in the health system's responses to COVID-19. And subsequently, we published over 20 situational briefs on our website, describing key aspects of the response in relation to migrants and refugees in different countries worldwide. Although there are some country examples of good practice, to date, migrants, refugees, and asylum seekers have often not been explicitly included in health system responses to the pandemic. COVID-19 has highlighted and exacerbated many of the structural inequalities which migrant populations often face. However, there is much diversity between countries, different migration contexts, and even between different regions within countries. So what really has been observed at both country and international level in terms of the impact of the COVID-19 pandemic on migrant populations over the last year? The examples and case studies presented by our speakers will provide rich insight into some of these different contexts worldwide. And without further ado, I would now like to hear from our 5 excellent speakers who have extensive experience in migration and health across academia, policy, and practice, who are with us today. To all our attendees, we would really encourage you to put questions into the chat, also with your affiliation and region listed, so that we can then address these at the end during the question and answer session. So moving on to our presentations today. Our first speaker, Dr. Santino Severoni, is Director of the Migration Health Programme in the Office of the Deputy Director General at the World Health Organization headquarters in Geneva. He has over 24 years of experience as an international senior technical advisor and executive. And since 2000, he has held senior positions at the World Health Organization European Office. I would now like to hand over to Santino for his presentation. Thank you.
Thank you, Miriam. Good afternoon to everybody. Thank you to Professor Luciano, for the invitation and organizing this event together with the Lancet Commission. Starting with my presentation, I will try to take you through a quick journey through the overall situation we are observing in relation to the impact of COVID-19 to migrants and refugees. This is a quite large subject. We've been monitoring and studying the situation because our colleagues in the emergency, they were on the forefront in guiding the country to respond to the pandemic. And now the next phase, which is the rolling out of the global immunization campaign, it's even more challenging in many aspects. And then there is already preparation and discussion on what is called Building Back Better. And again, we wanted to monitor and look carefully into the challenges and the peculiarities and the complexity that this part of population might be facing due to their own context. I'm going to refer with my short presentation to 2 studies we have run exactly in parallel, all those activities run by the emergency colleagues to guide the pandemic response, and basically a systematic review of the policy approach chosen by all member states around the world in terms of including or not including refugees and migrants in their own response plans. And then we try to reach out the migrants, the refugees, so the individual. And we ran in the past few months also a rapid survey targeting about 30,000 between refugees and migrants worldwide. The picture that came out from the I don't know if you can, yes. The picture that came out from the two studies is quite interesting. Many of the things have been confirmed by study or findings of other groups of research around the world. But the main picture came out that in one side, the COVID has been exposing refugees and migrants equally and in certain contexts. So there is a certain degree of different contexts where the exposure and the risk associated were higher than the resident population, upfront to a decreasing, a reduction of the global migratory processes, probably a little bit more complicated in the case of forced migration or displacement, where the triggers that were in many cases not able to be antagonized by the risk of contracting the COVID. And in fact, the population of refugees, especially those living into camp setting, had been having very peculiar experiences. In relation to the risk associated with a migratory process or with a displacement process, even if in terms of absolute number been reducing and the data observed, they were indicating about 20% of the growth expected for 2020, the mortality have been there as an element, proportionally decreasing with the overall number of migration movement, but still the let's say dangerous routes for migration and for displacement still kept being open during the pandemic and during the response, despite the lockdown and despite the measures introduced by each single member state. As I say, particular attention should be given to groups that we usually define in condition of more concerning vulnerability. If we look at the northern part of the world, those, and not only, but those in irregular situation or undocumented situation, they were the one being suffering the most in terms of accessing the minimum need of support and services for during the response and after, I would say. What are the challenges and health needs identified by the study we conducted? Well, the first information which came out, which is quite interesting, while the COVID pandemic response measures adopted by all countries around the world, they were somehow similar, with few exceptions, sometimes because of different, even political vision in terms of the possible how to handle the possible impact of the response measures. But in principle, most of the countries have been adopting similar modalities, and the element of case tracing and interrupting the chain of contagion and implementing physical distancing in order to respond quickly while waiting for the vaccine has been shared by most of the countries. A little bit who more tight, who less, but basically everybody followed those overall indications, plus the personal hygiene and all the other public health dispositions. This was not the case when we look at the approach to migration and refugees management. It was not the case for those group of population. Actually, we've been observing the full spectrum of attitude, country with a very pragmatic approach, which actually put in place very quickly and easily what we call universal coverage type of approach and measure, really considering the entire population present in their country, regardless the papers or the migratory status, as a people to be protected and to be included in the response measures. To the other side of the spectrum, countries which they basically implemented COVID response measure without including those population. And then in between, a number of intermediate positions or countries with specific interventions on refugee camps or large detention or hosting centers in case those that were present on the territory. The communication or an ad hoc thought, prepared communication plan strategy, also aiming at outreaching migrant refugees, was already present in 18% of the country we've been studying. So basically, this diversified, or allow me to say, sometimes not even coordinated approach in relation to this population have been posing a number of complications and a number of issues, which then reflected on this group of people, and also on the associated risk of managing appropriately the possible exposure or contracting the SARS-2 coronavirus. The situation in case of camp-like setting have been showing particular challenges related to this lock situation. So the implementation in many cases of basic required measures to respond to the pandemic, they were often not even possible. But this was not only the situation in camp or camp-like settings, but also in particularly poor or urban condition of social exclusion of certain cities or countries around the world. Interesting to see that although when the pandemic has been hitting on a different geographic area, the expected spreading of the contagion and morbidity and mortality related to COVID in camp-like setting didn't show or didn't manifest the concern and the preoccupation we were raising at the beginning in case would be interested. So probably the element of closed setting have been also playing an important role. But in this case, a lot of observation has been made in terms of adequate standard of service provided, informations, and also the impact on the social and private life of people living in those contexts. Services, particularly in the area of fragile economy, low middle income countries, or countries facing humanitarian crisis, or country facing large population. I'm just thinking to Lebanon, Jordan, for example, but not only, also Colombia, country facing large population of refugees or displaced population, have been certainly challenged by not only the disruption of the health system due to the pandemic, but also the incapability for lack of capacity and resources to really address the needs as needed and when needed. The socioeconomic implication and consequence basically are mirroring what the entire worldwide society is experiencing, with a particular underline on the fact that most of the population between migrants and refugees affected by the more harsh socioeconomic consequence also corresponds sometimes to the lower social level class in many countries around the world. The access to linguistic or culturally well-designed craft communication strategy and messages has been certainly challenging and insufficient. Evidence. Today there will be a lot of discussion about evidence. There will be, there was, and there will be also in the future, because this is a very important element. The overall picture which came out from the observation and the study we conducted is, again, of, in one hand, a really rich condition of availability of research, data, and evidence, but in the other hand, extremely fragmented, can be referred to specific context, single countries, group of countries, sub-national conditions, so very difficult to design a trend, or very difficult to have a, how to say, universal type of solid policy formulation. In addition, there is the element of different contexts while the phenomenon of migration or displacement is happening, and this element is extremely important also to tailor the evidence we are collecting and the consequent policy formulation. So basically, the lack of systematic collection of data by national health authorities is probably one element of concern, especially in the next future, where the discussion and the efforts in building back the system is going to be on top of the political agenda of most of the government. Then, in relation to the evidence observed, it was said, but also not a surprise to see a direct link between poverty, mortality because of COVID, and exposure to the risk to contract COVID disease. This is again not surprising and confirmed from different sources of the and the research we've been observing so far. The risk to be exposed to contract the infection of coronavirus basically has been traced to be higher in the migrant population, particularly even among the what we call regular migrants. This because have been proven during the response by the study we conduct that the migrant population have been playing a very central role in the response measure, either directly because healthcare workers and because migrants are representing a very large quota of the healthcare workers worldwide, particularly in the northern part of the world, but also when non-healthcare workers, they've been contributing indirectly because involved into the retail or essential services which kept functioning also during the lockdown or also during the acute stage of the pandemic. This survey targeting to explore, to assess what was the perception and the condition of living condition, how the COVID pandemic had been affecting life of individual, was the other scanning we conducted during the most acute crisis. This is a job done in collaboration with 2 universities and many other colleagues and institutions, which I'm thanking again. Was a snowball sampling, the way how we survey these 30,000 people with questionnaire translated into 37 languages. And the idea was to not really focus on the health dimension, but really to look at the social health dimension issues, including a particular attention to psychological well-being and social well-being as a possible additional distressor. So what we observed that we need to, and this is again, we can consider it not necessarily something new, but certainly is a confirmation that we need to give priority of attention to the poorer, to those in more concerning vulnerability. In fact, it was interesting to see that those living in more unstable, unsecure conditions because not having access to proper housing or living into camp or being unemployed or in condition of vulnerability, there were those neglected or unable to request support for health services, for health assistance, even in case of knowing to be affected by coronavirus, by COVID pandemic. And a big quote of these people, among the most poor, the most vulnerable, about 22%, they were avoiding to seek any kind of assistance because of fear of deportation. Because this was the other element which came out from our study, that unfortunately the lockdown or the interruption of contagion chain implemented by many countries in many cases have been overlapping or how to say, echoing modalities to control or to manage migration or irregular movement of migrants or displaced population. And this is very concerning, particularly looking at the near future. I will see in a second. The condition, the living condition, the uncertainty, the pressure of the infodemia about COVID, which has been tsunami everybody in all category, all level of cultural capacity, education, and conditions worldwide, have been determining a tremendous level of insecurity, fear, and this has been leading, as observed by our survey, with a very high incidence of not only insecurity, but also of possible behavior symptoms that can be reconducted to mental disorders or condition of mental concern, as depression or anxiety or panic attack, loneliness, or even recurring to the use of alcohol or drugs or other mitigating, apparently mitigating instruments for anxiety and stress. The impact on access on refugees and migrants have been serious in directed proportionate manners to the level of employment and housing. Those living, as I say also previously, in the most unsafe or insecure conditions, or those without jobs, or even those living on the street, they've been not only more exposed and infected, not asking support and assistance, but also they manifested the higher risk of mental disorders and basically accumulating all the possible effects of related to the pandemic. I'm going quite fast to conclude. So basically, what we learn in terms of issues needed or actions needed to really mitigate the process and good practices to be replicated. We are very concerned that public health measures aiming only at controlling the chain of contagion have been misused by a number of countries as a modality to manage or control migratory phenomena or displacement. This really should not be the case, but the contrary. In many cases, the pandemic and the measure implemented in response to COVID have been having a tremendous socioeconomic impact on the so-called the group of labor migrants, although the pandemic showed to the society the added value, the role of labor migrants, the positive role of labor migrants in our societies. This issue, anyhow, it's an unfinished story, because now that we are facing probably the most complex stage of access to vaccines and going back to a normality, we are actually exploring new territories in the sense that going back to mobility or freedom of mobility, there is a talking about immunization certified or licensed to move around once the vaccination will be received. But also the most important challenge to face now is the access for everybody to vaccines. So this situation is pretty fluid and developing, and we need to keep a very high level of attention and monitoring in order to make sure that measures which are absolutely fine and supported from the public health point of view are not utilized to control people movement, lives, and also freedom of deciding to migrate, or the need to be protected, or the right to health in case you are migrants or refugees. The access to health system as I say, we have been observing a quite high variety of situations, but basically it's important to acknowledge that a number of countries, a significant number of countries, switch into UHC type of approach. And basically why this is important? It's important because those countries show that the cost is bearable when political commitment is there. So the issue that we've been raising for a long time about the political choice, and then to adjust measures, technicalities, and finances and mechanisms in order to support the political choice is the way to go. And countries which they've been using this way, they achieved also good results in terms of managing the pandemic and also, how to say, mitigating inequity that pandemic have been triggering. The utilization of appropriate language communication and able to address migrant needs. This was quite, how to say, amatorial or highly fragmented. Imagine that in many of the camp-like settings, all the information that were provided by NGOs or humanitarian groups which they are working into the camp. So indeed, the element of communication was underestimated in terms of importance of serving and assisting this group of people up front of an epidemic of communication and miscommunication that have been observed related to COVID. Allocation of resources. There is already a big preparation and discussion in allocating resources to support the access to vaccines. The situation is very complicated. And there is already discussion to allocate resources to build what we call build back better the our world, our country, our systems. Well, this is very important that we are all well coordinated and making an impactful critical mass to make sure that building back better include also this group of people in a rational way and in a respect of human rights and right to health, and also on the freedom of movement and the respect of the persons. Evidence and research. What we are detecting is that indeed there is a positive element that we have a lot more information and data available to compare with a few years ago, but we need to really invest extraordinary efforts to switch higher the level of quality, consistency, and coordination on what we are analyzing and study. Otherwise, we are risking to have as I say, an infodemic of data difficult to be utilized to support policy formulation. And then collaboration between countries. The COVID pandemic showed that something that we know very well, that this could not be addressed by one single country. The same we have been telling for years and years about migration, and was surprisingly to see that preparedness in many cases was not included in this group of people, even in the case of countries with large presence of displaced population. And the approach, the response approach, was extremely incoordinated in relation to these people. So we need to do something about that, and this is supposed to be flagged in the proper context to our member states. Thank you very much for your attention, and ready to take any question if needed.
Thank you ever so much, Santino, for your excellent overview, not only of the findings of the WHO Global Survey, but also highlighting particularly the need to mitigate the inequity that the pandemic has produced. We'll save questions and answers for the end. There are some coming in. Just to remind all of the attendees, please do put your questions into the chat function and feel free to share with all of the attendees, not just the panelists. I'd like to introduce our next speaker now, Dr. Özge Kaman, who works as a senior researcher at the Center for Sustainable Development of the Earth Institute at Columbia University. She also holds an Associate Professor of Public Health title in Turkey and is a member of the Lancet COVID-19 Commission Secretariat. So handing over to you, Özge. Thank you.
Thank you, Miriam. So I'll try to focus on social determinants of health and why they matter more than ever in the pandemic. So if I need to summarize Turkey's experience with forced migration, as you know, the migration flow that started in 2011 as a result of the conflict in Syria has been described by UNHCR as the greatest migration wave seen in recent history. And Turkey still hosts the largest number of refugees in the world. When we look at the populations affected by forced migration in Turkey, the country hosts around 3.7 million registered Syrian refugees under the temporary protection regime. And of these refugees, 99% live in urban settings and nearly half are under the age of 18. As of April 2020, there were around 455,000 irregular migrants, mainly from Afghanistan, Pakistan, and Syria. According to UNHCR, there were an additional 370,000 asylum seekers and refugees under international protection, most of whom were from Afghanistan and Iraq. So when we look at the healthcare in general for refugees in Turkey, we see that persons with temporary protection status and other registered refugees have legal access to public healthcare. The Ministry of Health has established a national network of migrant health centers, which act as publicly owned primary healthcare centers for refugees living in urban areas. And in recent years, the ministry has employed more than 1,000 refugee health workers who help in decreasing the language and cultural barriers in health service provision for refugees. In April 2020, the Turkish government published a circular announcing that COVID-19 related health services will be provided under the emergency service category for free, regardless of registration status, facilitating access to health services for all. According to this circular, every individual who approaches a healthcare center with a suspected case of COVID-19, regardless of their health coverage under the social security system, shall be granted access to testing and treatment free of charge. As of today, there is no publicly available COVID-19 related data based on variables such as socioeconomic factors, ethnic origin, or immigrant status. Therefore, it is not possible to know the rate of mortality and morbidity among refugee and migrant populations in Turkey. However, there are reports published by some international and local NGOs presenting findings from field studies with refugees and interviews with service providers during the pandemic. So according to these reports, we mainly see problems in primordial and primary prevention, which are mainly increased unemployment among refugee and other populations affected by forced migration, and of course, decreased income in many families. We know that they need to continue working under risky conditions for the infection. And we also know that there are problems with shelter and living environments, like overcrowded houses with 4 or 5 families living in the same household, problems with social distancing and sanitation. We also know that there are problems in accessing healthy food, and the prevalence of nutritional deficiencies has increased. We also know that there is a high prevalence of tobacco use and chronic diseases, which are also risk factors for the infection. So there are also stress-provoking factors like higher levels of uncertainty among refugee populations, increased stigma and discrimination during the pandemic. And despite efforts of the government and UN organizations and NGOs, there are still problems in access to reliable COVID-19 information and information about available services. There are problems in accessing personal protective equipment, and there are interruptions and delays in outreach and field work of NGOs and other institutions. We also know that refugees and many migrant populations have barriers in access to social services because of language barriers, lack of knowledge about continuing services, and limited number of phone-based or online services in multiple languages. So these problems in primordial and primary prevention affecting physical, mental, and social health actually in return affects the immune system of individuals and increase their vulnerability for the infection. And when we look at the problems in secondary and tertiary prevention, we see that there are difficulties in accessing COVID-19 testing and treatment despite the legal rights, and there is lack of proper quarantine and isolation opportunities. While the right to access to healthcare may be guaranteed by legislation, in practice, migrant groups experience barriers in access to care, including language barriers, cultural barriers, lack of knowledge about how the health system functions, fear of deportation, difficulties in accessing internet, and various socioeconomic factors. So we know that the virus itself does not discriminate, but social determinants of health do. So morbidity and mortality are not simply based on infections or other biological reasons. We know that there are underlying social, economic, and cultural factors, which in turn conditions the biological, physical, and chemical factors so as to cause diseases. And as you all know, we call these causes of causes. So it would not be wrong to say that COVID-19 has evolved into a worldwide social disease subsequent to infectious diseases such as tuberculosis and HIV/AIDS that are also associated with social factors. Considered from this point, social determinants of health are linked to the prevalence of the infection. Moreover, viewed from the consequences of the infection and public health measures, the social effects of the pandemic manifests itself more distinctively in disadvantaged groups, including migrants and refugees. Following his examination of a typhus epidemic in Germany in 1848, Virchow, as the father of social medicine, defined artificial epidemics. Virchow, who revealed the importance of social factors in the emergence and spread of epidemics, concluded that despite the biological causality, the underlying causes of epidemics are the problems in political and social structuring, and that disadvantaged groups are particularly vulnerable to both of these problems and the epidemics themselves. So following this, in the current COVID-19 pandemic, we clearly see that most countries are experiencing artificial epidemics among disadvantaged groups, including migrants and refugees. So we know that migrants' health should be on the agenda of policymakers and practitioners for a comprehensive and effective response, because physical, mental, and social dimensions of health cannot be separated, and all three dimensions are strongly linked to the social determinants of health. As key interventions, especially, of course, when thinking about the problems that we experience in Turkey and in many countries, there is a need for linguistically and culturally appropriate health education and risk communication. There's a need for adequate supply of personal protective equipment. We need to ensure universal health coverage, including full access to services. We need more effective outreach approaches like working with community leaders, cultural mediators, to have hotlines, social media interventions, telemedicine, including mHealth technologies and mobile services. And we also need to close the digital divide. Other key interventions include decreasing stigma and discrimination, increasing community participation, and of course, all countries, including Turkey, need to have sufficient funding and also to have more social protection programs. Modifying surveillance and reporting systems to analyze population groups according to different vulnerabilities is very important in many countries, and increasing intersectoral collaboration for more holistic and interconnected and also gender-sensitive policies and practices is important. Of course, here we see that health in all policies is a key concept. So we know that international migration is not a problem to be solved, but a human reality that needs to be managed. And migration-related policies should be protective, inclusive, and participatory, but at the same time should aim for independent and productive migrants with access to educational and occupational opportunities. We know that population groups are interdependent with respect to health, well-being, and peace. This means health and well-being of migrants and refugees in countries are not only important for themselves, but also important for health and well-being of host societies, human and financial resources of host countries, and for building and maintaining peace. So considering the inequalities that the pandemic made more visible and the artificial epidemics created by human beings rather than the virus itself, all countries need to have a human-based approach, an inclusive approach that leaves no one behind to control the pandemic and to promote health at the country and global level. Thank you.
Thank you ever so much, Özge, for that really timely reminder of why the social determinants of health are even more important at this time during the pandemic and also beyond in order to address migrant and refugee health effectively. But also thank you for highlighting some of the key interventions which can be used to address these gaps between policy and practice, which we often see both pre-pandemic and during the COVID-19 pandemic as well. I'd like to introduce our next speaker now. Professor Ietza Bojorquez is a professor researcher at the Department of Population Studies in El Colegio de la Frontera Norte in Mexico, where she is currently in charge of the surveys of migration in Mexico's borders. From 2007 to 2010, she was Deputy Director of Operations Research in Mexico's Ministry of Health. So handing over to you, Ietza. Thank you.
Thank you, Miriam. I'm very happy to be here and share some thoughts with you. Okay, now you can see my presentation, right?
Yes.
Okay. So what I'm going to try to do in my presentation today is to focus on what is special or particular in Latin America and especially in Mexico regarding the situation of migrants during the COVID-19 pandemic. I completely agree that the social determinants are a major issue during this pandemic, and migration especially has been called a social determinant itself. So I think there's a lot of things we could discuss about this. And my main points today are going to be first, that the health systems in Latin America need to adapt for the response to a changing mobility landscape in Latin America, which I'm going to describe later on. That the COVID-19 pandemic is an added challenge in this sense to a situation that was already difficult and needed to be addressed. That at least in Mexico, the response has been focusing on the emergency during the COVID-19 pandemic, and there is a need for a long-term or at least mid-term planning and actions, so that this long-term vision should be based on integration. And this is an idea that is not new, probably. I mean, many countries, especially in Europe and North America, like the United States and Canada, have been discussing and working on issues of integration for hundreds of years, literally. But this is somehow a new idea in Latin America and a new issue, and I'm going to tell you why this is the case. So this is the panorama of migration flows in Latin America, and especially what has changed more recently. Traditionally, Latin America was mainly a region of origin of migrants, of international migrants, I mean, and it was mainly a south-north flow, where many people were moving from Latin America, from Southern and Central and Northern America to the United States and Canada mainly. And there was also some flows from Southern America, especially to Europe. And these flows were composed of economic migrants, but also of refugees and asylum seekers because of the many conflicts that have been present in the region for decades. So the movement of, for example, Mexicans to the United States, it's one of the biggest population movements in terms of numbers. It's in the thousands of millions of people. And this was traditionally mainly an economic migration, But it has become more and more an issue also of internal displacement due to violence in Mexico. So it has changed in its composition and its roles and many characteristics that are relevant for health. We also have a major movement, which I put there in the yellow arrow, which is the exodus of Venezuelans leaving their country, moving mainly to the neighboring countries in South America, Colombia, Brazil, Peru, but also moving even further down to the south to Chile and Argentina even. And this movement of Venezuelans is very important since it's because of the numbers first, because it has also been in the millions of persons, but also because of the rapid way it has developed. So in the course of a couple of years, Colombia received 2 million, it is close to 2 million now of Venezuelans living in Colombia. So this has required of a very rapid response from the health systems in the region. And another movement that is important, maybe not so huge in terms of numbers, but also important, is the movement that has become, it used to be an in-transit migration, but it was not just economic migrants, but it was composed of also of refugees and asylum seekers, displaced people running from violence in different countries, especially Central America. So persons coming from Honduras, El Salvador, Guatemala, some of them, have been moving through Mexico, aiming for the United States for decades. But more and more they are coming because of displacement due to violence and climate change, natural disasters. And there was this new phenomenon that was called the Caravans of Migrants, where people tried to join together and travel together through Mexico because Mexico was becoming so dangerous to cross. And it received a lot of mediatic attention, so it was a pretty well-known phenomenon. But the thing with the caravans was that the composition, the demographic composition of people moving in the caravans was slightly different to the one of the traditional movements through Mexico. So we are seeing more and more women, families, children, unaccompanied minors moving through Mexico. We also have a greater and increasing numbers of persons coming from Africa, traveling to South America, and then through Central America and Mexico, also aiming to the United States. And many of these movements have been delayed or stranded in the different borders within the region, and especially so now during the time of the pandemic. So I think that the major change, maybe, or the two major changes in the migration flows in the region are, first, that we are seeing increased flows in some areas we didn't see them before, and we're seeing a different composition of the population, both in terms of the nationalities and the gender and age distribution and the reasons for moving. And also that we're seeing more and more a change from transit to permanence. And this is what is very different, because usually, traditionally, the health policies for migrants in Latin America were aimed for a region that was an ascending region. So there were no many policies in place to care for immigrants or refugees within the region. So this is a very big challenge for many countries in the Latin American region. Okay. So what is going to happen now that we have the COVID pandemic? For Mexico especially, what we have now is an uncertain mobility pattern. We don't know what is going to happen. First of all, as you are aware of, there has been a change of administration in the US. So we are expecting an important change in migration policies. Even some orders have already been issued, and maybe Paul is going to speak a lot more about this further on. But the main issue for Mexico is how the previous migration policies were causing many people to become stranded in Mexico, especially in the US-Mexico border, but also in the Mexico-Guatemala border, because the Mexican government, as well as some governments in Central America, were responding to the what was called a migration crisis of people moving through Mexico, aiming for the United States, by putting in place migration controls of their own. So we have people stranded in both borders of Mexico. And if the US migration policies change, that can mean that this situation is going to change too. So the response of the health system has to change too. We also have the issue of the possible effects of violence, criminal and political violence on migration, on population movements, displacement too, and also of the natural disasters that could be increasing in the next years. So we don't know what the result of all of this is going to be, what the final result of this combination of circumstances is going to be. But probably one of the things we're going to see is that people is going to stay for longer periods and maybe become immigrants in Mexico, as in other countries in the region. And the photograph I'm putting here now is a photograph of what used to be it's not really a camp, but it's a group of persons who were asylum seekers in the US, that they were returned to Mexico as part of the migrant protection protocols that make people wait in Mexico till their migration case or their asylum seeking case is resolved in the US. And they have been in Mexico for so long that they are now having this milpa, this corn growth. And they are like being prepared to live in Mexico and to stay in Mexico. No? So how the Mexican system responds to persons who are coming to Mexico with the aim of crossing to the United States, but are finally staying in Mexico is going to be a very important determinant of health in this population. So I already talked about some of these impacts of the COVID-19 pandemic and over people on the move in Mexico. There were the border closures and the increased controls, migration controls. The asylum process was delayed, both the asylum process in the US and the asylum process in Mexico. So we have persons who used to wait in the southern border of Mexico, maybe 2-3 months to obtain a permit to go across Mexico regularly. And they are now having to wait like 7, 8, 9 months in the southern border. So the basic needs are not being met in many cases. Migrants in Mexico and refugees, asylum seekers are not mainly living in camp settings. They are living in shelters that are mostly operated by civil society organizations, including religious and non-religious organizations. And these shelters have been struggling in this situation, first because they have no enough resources for the amount of persons they are seeing now that people is getting trapped in Mexico. But at the same time, because they are trying to contain the transmission of the virus within the shelters. So in some cases, they had to close the shelters, which meant that many people had to stay in the streets. There has now been scenes of many people staying in the street outside of these shelters and living there basically for weeks. And some other needs such as education are really not being met because the whole system in Mexico has developed in terms of in-transit migration. So there are almost no provisions for things like education, integration, cultural integration, etc. So there is a huge disjoint between migration policies and health policies and between the agencies that care for migration and health in Mexico. So that the actions that the migration areas are taking are not coordinated with the actions that the health ministry is taking. So sometimes that makes the situation even more difficult. And in terms of the health system, I think one of the major lessons learned was the rapid response by civil society organizations. They did a lot of things very early in the pandemic. They searched for information, they transmitted that information to the persons staying with them in the shelters and in other services that they were providing, health services among those. And this was not met with a rapid response by the governmental agencies. That was more delayed, but it eventually came. And the response by the government and international organizations was in terms of an emergency response, which is also, it's logical. But at the same time, it hasn't yet evolved to a more comprehensive set of responses. In Mexico, migrants and refugees are entitled to health services, but there are a lot of barriers, nonetheless the administrative barriers, because in order to receive care, you have to present some papers, some ID papers that many migrants don't have. So that's one of the barriers, but there are many others. There's also a chronic unequal distribution of access to care, even for the Mexican population, but it was made worse during the pandemic, and it affects especially migrants, refugees, and asylum seekers and people on the move. Because we have a fragmented system which is composed of private and public providers and financing systems and a combination of social security and care for the population without social security. And within the system, it usually, this system facilitates this unequal distribution of access. Migrants can access the public health system, the governmental provided health system, which is the system with the more problems of funding and functioning. So they really have difficulties in that sense. And the other issue that I think is very important is that there's a huge implementation gap between the health policies and the implementation of the policies for migrants, refugees, as for other populations. So Mexico, as other Latin American countries, in the paper has very evolved policies, even for migrants. And so all health policies are based on a framework of human rights, and also migration policies are based on a framework of human rights. But the big issue is how those policies are implemented, how the secondary legislation is passed or not passed or enacted, and also at the level of the operational level, the street level bureaucrats. There are a lot of barriers for really realizing the right to health. So to go back to my main points, first of all, we have a changing pattern of migration flows in Latin America that has been evolving in the past decades, but it has been evolving more rapidly since the past maybe 10 years, and especially in the context of the COVID-19 pandemic. And the health systems need to adapt to that and have been doing that, but with different degrees of success. The COVID-19 pandemic is an added challenge to all of the above. And in Mexico, in particular, the response has been focusing on the emergency situation, but a long-term vision based on integration is required. And that's it for me. Thank you.
Thank you ever so much. Yeah, it's not only for the in-depth insight into the context of migration in Mexico, but also for highlighting that important point about moving from emergency responses into longer term responses, which I think applies to a lot of migration contexts worldwide and is a very useful insight. So thank you ever so much. Our next speaker, Dr. Paul Spiegel, is the director of the Johns Hopkins Center for Humanitarian Health and professor of the practice in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health, where he lectures and undertakes research in humanitarian emergencies. Previously, he was a senior United Nations official in the UN Refugee Agency from 2004 to 2016. So handing over to you, Paul. Thank you.
Great, thank you, everyone. Miriam, are my slides correct? Can people see them?
Yes, thank you.
Okay, thank you. So thank you, everyone, and thank you so far to the speakers. It's been, as always, very interesting. I want to ensure that we have enough time for questions and answers, so I'm going to make my presentation a little bit shorter. I have really 4 main points that I want to say, and then I'll just show you some of the slides to try to explain why I'm making them. Number one is that we need to ensure, or we need to advocate against governments using public health, or rather abusing public health orders to further an anti-migrant, anti-refugee, anti-asylum seeker agenda and policies. And I'll show you some examples of what has happened in the US here. In order to do that, I think we need to provide very strong evidence-based policies that can counter the arguments when, or at least the misperceptions of how public health has been abused. We need to be able to strongly advocate, not just with necessarily a government, but when some governments, such as the past administration here in the US, were impervious to evidence-based arguments, we need to be able to make sure and try to prepare for the next leaders when they come in. And that's what we tried to do with the Biden administration. And in order to provide recommendations, they cannot just be evidence-based, they also need to be practical and take into account different situations. So those are my main points. I want to just show you briefly now what's been happening on the US border. And this I took from the Customs CBP, the Customs Border Patrol website yesterday. And one looks at what was happening in 2019 and then a significant reduction across the border in 2020. But you can see here, right here, March 20th, 2020, there was a significant reduction from 34 to 17,000, and then it's slowly been increasing. And one can see right now, the 2021, that it is higher, and likely with what President Biden has been proposing, which is to change some of the restrictions that have been occurring, there is likely with that, there will be an increase in migration across the southern border. And what does that mean in terms of potentially COVID? So in March 20th, 2020, and that's where you saw a significant reduction across the border, in the southern border, Centers for Disease Control and in the US Health and Human Services stated a public health order, which basically on both sides of the border, north and south, Canada and Mexico, but really trying to target the southern border, the government said that there will be no more crossing for asylum seekers, migrants. They closed the border. Yet the border was still allowed to have Americans, of course, crossing, green card holders, commercial traffic, and other numerous exceptions that were made for students, etc. So what happened is this was, I think, a very good example of an order, a public health order, that was not meant to actually stop COVID from going across the border and into the US when you have such a porous border continuing and only trying to affect one group, which were mostly migrants and asylum seekers. So the evidence to be able to show that this is going to have an effect is minimal. And in fact, particularly at that time, things are changing in the pandemic, but the US had a much higher level of transmission than actually what was occurring in Mexico at that time. And so there were a lot of major issues with this order. Furthermore, there is, of course, the international refugee law that states that asylum seekers should be able to cross a border for their own security when fleeing persecution. And there was a US law as well stating that asylum seekers have the right to seek asylum in the US. So this law circumvented across the board all of those areas. I am going to the next slide here. Then what happened in August 30th, a second rule came out. It went into the Federal Register, which allows usually 60 days. This was 30 days for the public to be able to respond. And so we and a bunch of others responded quite vigorously. And this rule was actually proposing future epidemics and pandemics. This is proposing that not the Health and Human Services, so not the equivalent of a Ministry of Health, but the Law and Order, the equivalent of Interior Ministries, DHS, Department of Homeland Security, and Department of Justice, who don't have the expertise in this area, were able to say that they can declare if there is an increase in epidemics, and this can be everything here from a pandemic to something, actually, they talked about some of the quarantine and other diseases such as syphilis and gonorrhea, which are classic diseases that are that migrants and refugees are screened for ahead of time. These can be declared in a country, and then that would stop people from that country and people transiting that country to come into the United States. So the breadth of this law and the potential for misuse, or this rule, is quite extraordinary. We wrote, as many others, we had a campaign to use evidence to try to say why this should not happen. And then, unfortunately, it actually was passed Wednesday, December 23rd of this past year. The rule was passed, which actually gives a tremendous amount of responsibility and a potential abuse by the Department of Justice and the Department of Homeland Security to stop asylum seekers and migrants coming into this country. So I mentioned here, we actually we got together a group of professors across the US primarily, sent letters to, at that time, Secretary Azar, and at that time, Dr. Redfield of CDC. And then for the next order that came out, the proposed order, we sent to the DOJ and the DHS, the Department of Justice, and the Acting Department of Homeland Security. We wrote a bunch. You see a New Humanitarian talking about coronavirus and halting of asylum. And then we wrote some editorials in The Hill, which is a newspaper that is very much focused towards Congress, about how COVID-19 public health is being abused and should not be allowed to be able to affect asylum or stop the rights of asylum seekers. And then, so that was our advocacy. And I must say, for the most part, it appeared at that time in that administration to fall on deaf ears. But we didn't just say this is wrong. We tried to come up with some key recommendations to make sure that when people are crossing a border, whether they be economic migrants and or asylum seekers, and I clearly understand that's a false dichotomy, but we need to be able to categorize somehow some of these issues. It was to be able to strengthen public health decision-making and contingency planning and funding. It's clear that currently along the border, there are not sufficient public health officers to be able to either take COVID testing, to be able to screen people. There are insufficient regulations right now in terms of physical distancing. You have unaccompanied minors, and there's concerns about trafficking. So at times, while we do not want any detention for these groups, at times that may not be, it just may not be feasible to say no detention. And is there enough space in these detention areas, and how can you deal with these areas, particularly if you're unaccompanied minors, to make sure that you have proper standards. And one of the areas that we talked about, so we want to avoid congregate facilities whenever possible. But I think one of the biggest issues that has come up is that it depends on how many people are crossing a border at one time. And if you have, as there were, as you saw in 2019, tens of thousands of people crossing a border in a month, it makes it extremely difficult to be able to operationalize some of the recommendations that we are making here. And that does bring a government, whether it be at that time the Trump administration or now the Biden administration, it makes it extremely difficult to be able to have a border that allows asylum seekers and migrants to cross over, to adjudicate their cases, to try not to put them into congregate facilities where COVID will spread very quickly. How does one do this when you have either a limited capacity or just too many people crossing at the border? These are some of the more pragmatic issues that I don't think we and or the administration have been able to address sufficiently at this time. So while we may be able to, and I'll end here because of time, while we may be able to make recommendations to try to keep not closed borders, how will we be able to do this in an operational and practical capacity where we make sure that the migrants themselves have access to proper health care and testing, and that spread, especially at the border, is reduced? Thank you, and I'm going to end there, and I look forward to speaking further about this.
Thank you ever so much, Paul. for that demonstration of very clearly of the impact of public health orders, but also restrictive migration policies on migrant health during the COVID-19 pandemic. And I think some of those challenges that you've raised around actually bridging the gap between, evidence-based work and actually moving to pragmatic and practical solutions and issues are ones which are very relevant both now during the pandemic and beyond. So I'd now like to introduce our final speaker, Dr. Apostolos Vezis. He's a medical doctor and the director of the Medical Operational Support Unit of Médecins Sans Frontières, or MSF, in Greece. Prior to his work there, he worked as head of mission and medical coordinator for Médecins Sans Frontières and Médecins du Monde in Afghanistan, Azerbaijan, Russia, Albania, Egypt, Georgia, Greece, and Turkey. Thank you very much, Apostolos.
Thank you, Miriam, for the introduction and also for the invitation. And also, I would like to thank a lot of the colleagues who just talked before me. So they said everything, so I have nothing to say now. Secondly, they said the most important part, so the rest of the people who are following, they're going to leave the webinar. So it would be me and you and probably a few people on the panel. So I'm going to touch from my side a bit the situation with migrant refugees and asylum seekers who are stranded in Greece and what is the impact of COVID-19 on them. So just for understanding, this also through the eyes of MSF, who is present at the moment on the island of Lesbos, Samos and Athens, through work that's being done for many years. Greece, just for information, has a population of about 11 million people. And it has about 120,000 asylum seekers, refugees following the refugee crisis, so-called refugee crisis of 2015. And having in March 2016, the famous EU-Turkey statement, we have today a puzzle that has migrant asylum seekers who are being stranded on the Greek islands and also on the mainland in the camps. So it's a situation that is, and also you have people also living on apartments, but it's quite a challenging situation for all those people. Just to give you an impression and an example, on the island of Samos, the camp is made for 648 people, where the population is at the moment about 3,382. So overall, there are about 17,000 people who are stuck on the 5 Greek islands. So this is a bit of the housing of the people, how the camps they look. That's the picture of Old Moria, the New Moria, the island of Samos and Chios. And that's Samos, that's Lesbos, the New Moria camp. And you can see how they look a bit more close by, how the housing, and when I'm talking about housing, we're talking about tents for years now. And these are recent pictures, they're not old pictures. So continue a bit with the situation of those people that they are facing on those camps. And I come back as Santino is together with us when he presented in 2018 the report of WHO related to health of refugees and migrants in the WHO European region, was mentioning that refugees and migrants are generally in good health. That's true. But there are a risk of falling sick in transition and when they are stranded due to poor living conditions, inadequate food and water, increased stress and lack of integration. Something that it's a perfect example of Greece and can be taken into consideration. And that's where we've been documenting from our side the impact of those situations on the mental health with depression, PTSD and anxiety being the main reason, especially increasing following the Turkey statement. With the main morbidities among the children through our clinic, we've been seeing upper respiratory tract infection, diarrhea, skin diseases related to living conditions, or related to the hygiene related morbidities we've been seeing. While when it comes to the chronic medical conditions, we see hypertension, diabetes and asthma, something that is important to see now for the COVID-19 issue. So if we come back to the COVID-19 and everybody have been talking around the world, stay at home, wash your hands, keep the distance. The pictures you saw before, I don't know how much and easy it is for people living on those camps. This is what does it mean living in a refugee camp in Greece, while for example, people going to the supermarket, they need to take a specific number in order to reach that activity. This population, even though the recommendations of the European Center for Disease Control and WHO are making very clear that there's no evidence that would suggest the transmission of the virus is higher among migrants and refugees. or at the same time, there's no evidence that quarantining people in reception and detention setting is effective to limit transmission. Those people have been under the restriction of movement since 17th of March, following a joint ministerial decision and the National Committee for the Protection of Public Health Against COVID. While this did not happen for the rest of the population, the same time, the number of people that have to move out of the camps during the day, it's limited. From 7 o'clock in the evening until 7 o'clock in the morning, people that cannot leave. And sometimes people have a small number of them. So when the country has been going through different situations following COVID, including the big lockdown that Greece started recently, that makes also the life of people on those camps and for the refugees more and more difficult. On the other side, you will see that the lack of services or no services provided to the people both on the islands and the mainland, where there are no doctors or there were regular visits on many camps, so that's not possible to provide services. Or where you can see an apartheid in 2020 in the European Union, where the hospitals are asking, first of all, for COVID-19 negative tests before they're seeing a patient on their hospitals, and that was the case on Ritsona camp and in Ofita, but at the same time also on the island of Lesbos. So even though from our side as MSF, we've been trying to adapt the current programs in order to not to stop the program, we've been calling for evacuation of vulnerable people, including people more than 65 and people with chronic medical condition. We've been creating the green zones on the camps. We've been improving the wash facilities. At the same time, the aim was to contribute on COVID-19 triage, isolation, and we've been calling about testing and also questioning the quarantine and the impact of the quarantine. With the data until the end of November, there were about 218 people at risk for COVID still stuck on the Greek islands. So the Greek authorities have been moving slowly, those people. So the adaptation of services was something that we created also an isolation unit that was closed down by the authorities. And of course, everybody knows what happened after that. With the closure of that center and identification of cases in Moria, we had the fire and people on the streets. So on the left side, you can see how an isolation unit was looking at MSF. And even though the tents are belonging to UNHCR, this was the first isolation unit was created on the new camp of Moria 2, where people were kept together, positive cases, close contacts, and the members of the family. So we continue to do the vaccination, maintaining and keeping all the rules following COVID-19 in order to ensure the minimizing the different types of other outbreaks. That said, what does it mean? Because everybody thinks that for COVID have been impacting only the normal population. So when I'm saying normal population, I'm talking about the Greek citizens. And what about people who are living on those camps? So during the first wave, we saw that the main cases of confirmed COVID have been on the camps on the mainland, where there were the camps of Ritsona and Malakasa and the hotel. And this due to the fact, not because there were cases, there were tests in place, but because there were positive cases identified on the closed health facilities. And then we had those cases appearing inside of those camps, and those camps were put under the lockdown. So the transmission continued. And then when it comes to the second wave, we had in total, following the work being done by a group of colleagues, following Dimitris, Elias, Miriam, etc. It's a work in process. They were collected between 26th of February until end of November, about 1,900 cases, with majority of them on the facilities on the islands, then on the mainland, plus also the new arrivals. And then you can see that the impacts of COVID on the population living in the reception and identification center on the island have been more than the one living on the open refugee facilities on the mainland, and more than the general population. So you can see that the risk of infection increased when you move from the general population to the refugees living on the open refugee facilities and to the refugees residing on the Greek islands. That goes from 2.45 to 2.86. So we have a risk 2.5 and 2.8 among those population versus the general population. So that's what interpretation is when we want to interpret also the incident proportion of COVID among refugee population. On the other side, you can see that on September 17, there were almost half of the COVID-19 patients hospitalized in Athens and in Attica. They were coming from the host site and the city center. So most of the patients, due to the fact that the situation, both for the economical migrants, but at the same time, people living on those camps, it's quite difficult. It's important to read that the rights of health, it's meaning leaving no one behind. And of course, we need to consider public health and health together with migrants and refugees on it. But without real action, it is just a slogan, because money was not an issue. So from 2015 until November 2020, Greece have been benefiting from 2.81 billion euros. And this fact does not reflect what situation is on the camp. And of course, before we vaccinate everybody about COVID vaccine, and this is the big discussion we're going on, we need to vaccinate everybody against indifference in front of this situation. And I would like to remind you, on the 22nd of January, the Council of Europe, the Committee of Bioethics, had also issued recommendation to include the most vulnerable population, including migrants and refugees, on the vaccination, because it's very nice to see that people in Europe that are more than 85 or 90 years old are getting vaccines, but not refugees and migrants. And I think it's important to maintain and keep the masks, because it's very effective on protecting us for the transmission, but at the same time, not to close our eyes in front of the situation for the refugees that are facing in Greece and in Europe. Thank you very much.
Thank you ever so much, Apostolos, for giving us that insight into Greece and the challenges, particularly for migrants who are and asylum seekers who are in situations of transit during the COVID-19 pandemic. But also, I think the need to include, you finished with a very important point there about the need to ensure equitable access to vaccination for all populations during the current and future pandemics. So thank you so much to all our speakers for your excellent presentations. It's very, very, very clear from the presentations, not only the diversity and complexity in each of the migration contexts and countries that you've represented today, but also that it's very clear that we must include migrants in the public health responses, both during COVID-19 and beyond, and that in order to have an effective response, but also effective public health systems, we have to think about those most vulnerable and marginalized within our societies. I think also many of you mentioned in your presentations that there are some opportunities and things that can be learned during the pandemic. And this opportunity globally to strengthen health systems, to work towards universal health coverage, which includes all populations, and to really ensure that we are leaving no one behind. These are some of the opportunities that perhaps we can see moving forward, both in these phases of the pandemic, but also beyond. So I now would like to move on to the question and answer session. We've had quite a few good questions coming in, some of which are to specific speakers, and also some of the questions have been addressed or are being answered on the thread at the moment. So I'm going to choose a few questions and direct them at some of our speakers. If all the speakers could put your videos back on now. Thank you ever so much. So first of all, I'd like to start with actually two questions that came in during Santino's presentation. From Manuel Carvalho. He mentioned about referring, Santino, you referred to universal health coverage and said that some countries were providing access to services, but then mentioned that they should also be providing access to COVID-19 services. So his question was, does this mean that even in countries providing equal access to healthcare, they won't necessarily be guaranteed access to the vaccine? And a sort of linked question on a similar topic also for you, Santino, is that in the topic of universal health coverage, the 43% of countries who who do not provide access to UHC, does this include countries where, for example, UHC for migrants, does this include countries, for example, where even countries where universal health coverage is in the constitution, for example? So are migrants still excluded even from countries where constitutionally there should be a right for them to access healthcare? And those are sort of two linked questions, one from Manuel Carvalho and one from Joanna Neto. So that's first for Santino, thank you.
Thank you, Miriam, and hi to Manuel. Well, the access of COVID vaccine is the challenge we are dealing with. That there is a very loud advocacy, not only WHO but IOM and UNHCR. We just closed on Tuesday the the last executive board with all member states of WHO. It's a governing body where the preparation of the assembly is taking place and the action recommendation request of action to WHO are put forward, and was very loud the issue of having an approach towards equity, including also refugees and migrants, not only those, but all the group of population might be in condition of vulnerability. Indeed, the situation is not so clear, because at this stage, and probably also following the issue on the news, countries are kind of struggling to continue or to keep up with the planned immunization campaign. So indeed, we are not concerned for the involvement, and what we are asking, not to treat migrants and refugees in a different way from the population, but to treat them as the rest of the population. So we have information that in many cases, even here in Switzerland where I'm living, migrants are those at irregular condition, irregular situation, certainly included in the plans and call for accessing to vaccination. Concern in the northern part of the world is for those in irregular conditions, which cannot be easily reached. This situation is much more complex when we are looking at countries with a low or middle level income. In this case, the challenge is really the procurement, to be able to pay for having vaccines available for the population. We have already heard from member states with large refugee presence the willingness to roll out immunization also to refugees and migrants, but they are asking for help to procure vaccines. And there is a quite big concern in terms of indeed, with the current situation, that all countries will have the equal access to the vaccines in the coming months. So the situation is pretty blaring, and the issue is very well felt. From the WHO side, in very close collaboration with key stakeholders, there is also being developed a buffer, humanitarian buffer, which is supposed to be stepping in supporting those countries in higher need. But at this stage, the access to vaccine, regardless the UHC approach, it's certainly something which we need to pay good attention. Sorry, the other question, Miriam, I didn't took note. What was the second question?
The second question was, even in countries where constitutionally universal health coverage should include access to healthcare for migrants, are there some countries where this does not apply?
No, well, again, the discrimination is between regular and irregular migrants. Situation might be totally different for those in irregular situation because of their own condition of marginalized living and settings. During the COVID, at least on the study that we ourselves conduct, we saw an amplification of the health systems barrier in accessing to services for let's say migrant or also non-national living in a country, but also in a regular condition. And this can be certainly a major or quite sensitive issues in a moment of disrupted services. If you imagine that the access for treatment of chronic disease is something that have been highly flagged in terms of relevance during the COVID pandemic because of the postponement and because of the reprioritization of service provision to the overall population. So in principle, those which they're having constitutionally not, but the barrier to access the service, those are there, and those need to be navigated by all, and particularly those which they're having some difference in terms of capacity at the starting point. Over.
Thank you, Santino. And the next question for Paul, I'm going to ask from Julie Shotland-Cox. What are the different hypotheses for the unexpectedly low rates of COVID-19 amongst refugees, migrants, asylum seekers in camp settings?
Yeah, great, thank you. Hugely important question, and there are the problem is we sadly do not have very good information at all, and so there are hypotheses, but there is very little data to support them either way. I would just emphasize that it's reported as opposed to what may be the case, and there are a couple of broad hypotheses. Number one is that transmission has been quite high amongst many settings. Let's just, for ease, use the Rohingya refugee population, which I'm most familiar. There could be very high transmission. Oh, can you hear me? Because my things aren't leaving here. There could be very high transmission, but actually relatively low hospitalization and death for a variety of reasons, such as a very, very young population, mostly populations outside. And there's also discussion, not just in refugee settings, but in all settings in some of the low-income countries of protection due to either whether they're corona-related or other infections, including even BCG, of which there still is insufficient evidence. The other hypothesis is that there actually is for relatively low transmission, and consequently you're seeing relatively low hospitalizations and deaths. I would just end by saying that there are discussions in some places, like in the Rohingya camps, that actually the deaths were higher than have been reported, but because of concerns about being sent to, or rumors about being sent to an island, about being quarantined, that they're actually deliberately trying to not let the authorities know that there have been deaths. So the most frustrating part is that we don't have sufficient data to be able to really understand what is happening, despite numerous attempts to do so.
Miriam, can I add just one little thing?
Sure.
That Paul's, yeah. Thanks, Paul, for the explanation. I think, first of all, the people living on the camps are not considered to be people. They are just numbers. They are not included on the services being provided to the general population. So the testing is not in place, services are not in place. So what I just mentioned before, and because this is a work in progress and you have to wait for some more weeks, but it's very, very clear from the data who are already underreported, from the data who are not completed, that the impact of COVID on the people living on the worst islands camp versus the people living on the camps in the mainland versus the general population shows that there is a difference, and there is more high risk on infection. So when it comes to the death case, I mean, so far officially have been reported only 2 death cases about people living on the camps. But so far there have been no data from the authorities mentioning who are the people who died, are there, which migrants they are, who they are. So I think it is an important thing how these people are included on the data collection system. And I think for me, it's important to make very clear, because there was a big discussion yesterday from WHO on the collection of data for migrants and refugees. I think we don't have to separate people living on the European territory or in the country from the rest of the population. Including them on the data and analysis, it's important also to take decision. Because I mean, at the moment, the situation is by saying, these are young people, or they will not have an impact. This is just something that is not really proven to be true when the data is in place. So I think at the moment, the issue has to do with the services provision and the data analysis of those people.
Thank you very much, Apostolos. And just that really highlights the complexity and differences in data collection between different migrant populations worldwide. I'd like to now have a question for Özge. So there were 2 sort of related questions around vaccination, one of which by Elena Rus. So are refugees and migrants eligible to receive the COVID-19 vaccine in Turkey? And if so, how has this been organized? And the other one, actually not specific to vaccination, but from Lawrence Gruer, has the cost of free COVID-19 services for all migrants and refugees been borne entirely by the Turkish government, or have they received outside financial assistance?
Thank you, Miriam, and thank you for the questions. So for the vaccination question, actually, the vaccination started at the beginning of January, and the campaign is quite organized. And it's coordinated by the Ministry of Health at the central level. But we unfortunately do not have enough information until now about the situation with refugees and persons living with temporary protection status, because there's no officially available information on that. But we know that actually when we look at the demographic profiles of refugees and the host population, we know that the percentage of the elderly among the refugees are low when compared to the citizens, because the elderly population in Turkey is around 9%. Of all the population, and when we look at the refugees, it's around 2%. That's actually an advantage that the refugees are a bit younger. But of course, we all need vaccination, and the Ministry of Health will probably at some point give more information about refugees. The Medical Association in Turkey and many NGOs working with migrants and refugees are calling for more information about vaccination in migrants, and we hope that that information will be available soon. About the cost, Turkey actually did not receive additional funding for the cost of COVID-19 related health services for refugees until now. But the country has been receiving some funding from the EU to improve health services for refugees. But the government spending has always been much higher than international support, at least until now. Thank you.
Thank you very much, Özge. And a question for Yetsa. What do you believe are the opportunities for improving migrant health and ensuring the right to health for migrants in Mexico and or Latin America during COVID-19 and beyond? And how can these improvements be made more durable and sustainable long term?
Okay, first of all, I think the recognition of migrants and asylum seekers and refugees as an important part of the population, the recognition of their presence and of their healthcare needs, I think it's the main point. And secondly, as I was saying, the implementation gap, so that we don't have these policies that are very nice looking in the paper, but are not well implemented. So it has to do with secondary legislation, with training of providers, with a lot of things that have to be done in order for policies to filter down to the field. Yeah.
Thank you ever so much. And for Apostolos, over the years, while you've been working in migration and health, you have encountered, you've mentioned discriminatory policies and practices affecting migration health. Do you see political will as being one of the main barriers to improving migration health globally? And if so, how can we address this challenge?
Well, first of all, definitely it's a lack of political will. I think the so-called refugee crisis, dealing with 100,000 people, it's something that is not a crisis anymore. So I think the number of people, it is very small number of people. The bad living conditions, the deterrence, and the way how the people are being treated, it's part of a policy and a political choice of European Union and the Greek government. So for me, the idea how we can address it, as first of all, we need to address it both on European level and internationally, especially in European level where the issue is not the resources, because in certain other countries you can consider that probably the burden between brackets of the refugees is even higher, and it's more difficult for those countries to provide the services. But here you see that as I mentioned before, the 2.81 billion euros they've been delivered all this time does not reflect the situation. So in a way, there are a lot of barriers were being created, and recently was the barrier of excluding people from the security number that decreased also the access of people to the healthcare system. So for me, it is very important to consider, first of all, to put people on the center of the approach. Secondly, I think inclusion of refugees and migrants into the health system have been proven both scientifically, but also being lobbied by WHO, that we cannot consider a health without migrants and refugees. And especially during the pandemic, I think what is an important element is that dealing with the pandemic, if we don't consider managing all the rest of the population living on the country, that's something that we will not manage anyway. So for me, it's a situation of very sad to see it for many years. And personally, I've been living with this situation for the last 12 years. And this is something that is becoming a situation that for the local people or for the European community people is being seen a situation like, okay, well, this is normal. No, we need to change this normality. That's why it's important before we vaccinate ourselves against COVID, let's vaccinate our people against the indifference in order to address those issues.
Thank you, Apostolos. And finally, the last question to all the speakers. So what we have seen, sadly, over the last year has been that some of the progress in global policy progress, particularly, as well as progress at national or country level in improving migration health and integrating migrants into health systems, has been affected by the pandemic. And in some cases, there's been reversal of progress. How do we ensure that that migrant health and progress globally on improving migration health doesn't fall behind even further? Can you, each of you, suggest perhaps just one particular priority of how we should move forward now during the COVID-19 pandemic and beyond to ensure that all people and all migrants have the right to access health services and the right to health? So just one point from each speaker in summary. Thank you. Starting with, I'll start with Yetza, please.
Okay, so it depends on who are we. But I think one major reason, maybe this is my obsession and it's particular for Mexico, it's the secondary legislation. We need to really do some incidents in the secondary legislation so it is well attuned to the needs of migrants.
Thank you very much. And Apostolos?
This is a $1 million question because I've been looking at it in depth and trying to see what we need to do, you know, what we need to prioritize and stuff. So I think for me, yeah, it's not the issue of legislation. Legislation is in place. It's no issue of the money. I think we need to consider. I don't know. We need to consider that, you know, we cannot manage. I mean, I don't know. I mean, it's really I don't have an answer for that. Sorry for that.
I think maybe you already answered in the previous question, treating everyone as people. And so, Ozge?
I think one of the top priorities is to decrease stigma and discrimination, especially if I think about Turkey. The stigma and discrimination towards refugees is increasing day by day. And I think that's one of the most important topics that policymakers, decision makers need to work on. To improve migrant health and to improve health at the country level.
Thank you. And Santino? Oops, Santino.
Sorry,
Yeah.
Now, yes, sorry. Well, what can be done, what we have to do? Well, for sure, for the technical people, for those involved into the study and working on this area, we should definitely learn from the experience of this pandemic, because although this has been, and it is a drama, there are quite a number of interesting situations where we're supposed to jump on and to build on a better future for tomorrow. And only few months ago, only last year was so difficult to speak about UHC. It was a kind of an utopistic discussion. Now we have seen, with all the limits, with all the situation, being a reality in a number of countries. My main point, my main recommendation, because technically we know what to do, basically. But my main recommendation would be finally to depoliticize this narrative, this discussion about migration, health and migration. And the inclusion of refugees and migrants into our health systems have been showing that applying a public health approach doesn't harm anybody, even those which they're paying the bill or paying the taxes. The contrary, is protecting the entire society.
Thank you so much, Santino. And on that note, I'd like to hand back over to Luciano for concluding remarks. Thank you all.
So just a few words to conclude. It has been a very interesting webinar. Thank you very much to Miriam for sharing so well this event. Thank you to the excellent speakers for the very interesting presentations. Also to the participants, it was really impressive to see how many interesting questions came into the chat, and we apologize that we did not manage to answer maybe all of them, but we will follow up. We are going to see you hopefully online very soon again. The next webinar will be on the 22nd of February at the same time, 3 p.m. Central European Time. Thank you again also to the wonderful World Health Summit team in Berlin, to Nora Anton especially. And again, we hope to see you soon on this series of M8 Alliance webinars. Thank you.
Thank you.
Thank you.